This is Dr. Venkanna Pocham, Junior Consultant in the KIMS Hospital, Secunderabad. And today, moderator is Dr. Pankaj Kumta sir, consultant from KIMS same hospital, Secunderabad. Start, sir.
Well, thank you, Keshav. Thanks. Although Dr. Venkanna's Pocham is his official name, we do call him as Keshav, so we'll keep it short with Dr. Keshav right now, with the name and easy to discuss with him. So hi, my name is Pankaj. I'm a consultant here in the KIMS Hospital, Secunderabad. We are a high-risk unit which covers critical care and ECMO and some transplants. I'm honored to introduce my colleague and friend, Dr. Venkanna Pocham, or Dr. Keshav, as we call him, and he is also a consultant in our department. His major specialties in the neuro ICU, and today's topic, as part of the STEP program, which is the structured training and education program for the nurses, we'll be talking about prone positioning. Prone positioning is an important aspect of critical care, especially made mainstream by the COVID pandemic, and something which even the layman really knows about. So, and especially after the well-made guidelines and self-care guidelines of awake proning and all, it has become even more important for all of us to really understand why this proning is done, when is to be initiated, when to stop, and what to monitor, and when does it really help, and when it does not. So we'll be continuing this. So the session will be first, Dr. Keshav will talk about the positioning, he'll talk about the procedures, everything. And we have a small session of MCQs and questions so that we can just review the findings and understand which will help us focus on the important aspects. And then we can take up questions and any suggestions, comments from the audience. Yeah. So before wasting any time, let me hand over the thing to Dr. Keshav or Dr. Venkanna.
Okay, sir. Thank you, sir. Then we'll start the class. I'm happy to be part of the class, and to share my our institution experience with you, all the people, and we'll try to answer your doubts and questions also. Okay, sir. Should I start?
Yeah, please.
These are few slides regarding Euro Asia 2002. Yeah, coming to the topic, and the COVID second wave, we had a patient, 50-year-old male patient, presented to the ER with a history of high grade fever since 6 to 7 days, cough of some 5 to 6 days, and since 2 days there is worsening of shortness of breath since 2 days. In the ER, the patient is conscious, coherent, the temperature 101, and with the dehydration was tachypneic, and the respiratory rate was 35 to 40 per minute, and BP slightly low, 160, and the room air saturation was 86%. Then the patient initiated with the oxygen support with the first polymask, then and went to non-rebreathing mask as the SATs are not maintaining. Then other part of resuscitation, fluid bolus, and empiric antibiotic started. And the labs, CT chest is done, and the ABG is taken. Based on the labs and the CT screening, is found to be ARDS with secondary bacterial secondary pneumonia with type 1 respiratory failure. This is a CT. You can see this one. And for typical ARDS CT with the GGOs in the mid zone and basal zone, and the consolidation also you can see. Further X-ray also showing the depicting the bilateral consolidations. The patient shifted with the NRPM to the ICU. It was then more tachypneic and hypoxic, and then we initiated the high flow nasal cannula with the 40 liters per minute, and the secured with the lines, and started the first awake prone with awake prone initiated. Saturation will maintain around 88 to 90. This was maintained around 30 minutes to 1 hour, but still having high grade temperatures and becoming more tachypneic and not comfort in that position. So then antibiotics again further antibiotic escalated. Still the patient become more distressed, unable to maintain saturations. Then decided to intubate the patient, and we secured the airway and started the according to ARDS-net ventilation strategy. And still the after ventilation and mechanical ventilation also patient hardly touch the sats of 91, and the vitals also borderline, and the peak pressures were very high. Then the next step, then what to do next? Then the ICU team decided to go for the prone ventilation according to ProSaver trial. This is the ProSaver trial, which shows that prone positioning in the severe ARDS patient. The study concludes that in patients with severe ARDS, early application of prolonged prone positioning session decrease the mortality, 28-day and 90-day mortality. So coming to the core of the topic, the prone positioning in ICU and OT, but OT will show you some slides, but without out of the scope of the topic. Coming to the prone position, what is the prone position? In anatomy, the prone position is the position of the body lying face down. You can see in the picture, it is opposite to the supine position, which is the face up. Then prone, where do you use the prone position? During surgical procedure, which provides access to the dorsal aspects of the patient body. And in ICU, prone position ventilation, which was proposed in 1907, first applied the patient with ARDS in 1976, and the ProSaver trial also showed the decrease in the mortality and the increase in SATs. This is the slide shows the prone position in the OT. This is for laminectomy, the surgery, and ICU. We can see that the patient in the prone with the mechanical ventilation. This is as per definition, prone ventilation refers to the delivery of a mechanical ventilation, the patient lying in the prone position. It can be awake proning for the second sedated paralyzed patients, even tracheostomy patient, and in the ECMO patients also. Just a brief physiology physiology about the proning. How does it affect on the oxygenation? This prone position alters the mechanics and the physiology of the gas exchange, which results in the improved oxygenation. It's a multifactorial. We can see further in slides like physiological in the normal supine position where the heart is dependent. Here the heart is off label from the lungs, which leads to improved ventilation distribution. And second is the abdomen is unsupported, provided that it should be free from the base, and more homogeneous perfusion that leads to increased VQ matching. This slide shows that in ventral the heart is placing on the lungs like so there is you can see in the second there's a distended alveoli. At the same time blood flow is very low, so there is a VQ mismatch. I mean circulation and the aeration is disproportionate. In the prone position we can see that more dorsal lung is ventilated and it is having the circulation also, so there is ventilation and the oxygenation. This is the one crux of the prone position. This is a CT showing this one ARDS chest. Now coming to the indications, the ProSaver defines the severe ARDS patient is having the PF ratios less than 150 or FiO2 dependent more than 0.6 or P more than 5 centimeter of water, or refractory hypoxemia due to ARDS where PF ratio less than 100 or PaO2 less than 50, or prone ventilation has been used as a bridge to ECMO. These are some contraindications and the complications of the prone ventilation, where further we'll discuss in the detail. Some contraindications are severe shock, where they're unable to maintain without supports, acute bleeding, massive hematoxis or hemorrhagic shock, and fractures or trauma patient, and any cervical or spine instability or pregnancy. Is a modified prone can be used for pregnancy, and other patient with a raised ICP bleeds or CPP less than 60, or with a patient with the sternotomy or recent surgeries involving the sternum. And the relative contraindications are DVT treated less than 2 days or with the thrombolysis, and any chest tube with the air leaks, any major abdominal surgeries involving from epigastrium to lower abdomen, or recent pacemaker, severe burns or lung transplant patients, and the complications for nerve compressions, crush injuries, and any dislodgement ET tube, diaphragm limitations, retinal damage, transient reduction in arterial saturation, vomiting, transient arrhythmias. These slides in further slides will discuss in the detail. Coming to the techniques, there are two techniques are there. One is the manual method and the automated proning by rotoprone bed. Here we use the sandwich and flip technique, and the other one is the awake prone by patient with the help of team members. Another is the ceiling lift. Coming to when we initiate the proning, usually after 12 to 24 hours stabilization period of supine ventilation, it's not maintaining SATs, then we'll initiate the prone ventilation as early as up to 36 hours. But based on the ProSaver trial, if they initiate early initiation of prone ventilation, there is likely to be collapse and will be open and will be used good results in the acute exudative phase of ARDS. So as early as in the acute phase only we can initiate the proning. Coming to the monitoring, standard monitoring with invasive outlines and the central line ETCO2 monitoring, and for thorough endotracheal suction is frequency every hourly. As the patient is prone, the loss of pulmonary secretion will be there. Then regarding feeding, once prone, enteral tube feeds and usual mouth and skin care can be resumed. However, this feeding during prone ventilation can be complicated by emesis or increased residual gastric volume. In order to minimize such complication, we prefer a cautious approach to enteral feeding in the prone position. With proper positioning, the head of the patient slightly elevated, regularly monitoring, and judicious use of prokinetic agents. Here we start with the low trickle feed. After resuming, we'll start the full nutrition. Tube feeds should be temporarily switched off and the stomach emptied before reposition back to the supine position. All the patient in whom prone ventilation is performed require increased sedation and neuromuscular blockade. Here we use the infusions and based on hourly top up with the neuromuscular blockers. And coming to the duration, optimal duration of the prone positioning is unknown. Actually, the studies has been done 17 to 20 hours per day as ARDS ProSaver trial. Here in our institution, we use for 18 hours for the prone ventilation. And this highest study continued was at 28 days. Still, it was stopped after continued improvement or oxygenation, PF ratio is more than 150, or FiO2 0.6, or P less than 10 centimeter of water. Then once we started the prone ventilation, then assessing the response. The sustained improvement in gas section, at least more than 10 mmHg of PaO2 on stable ventilated setting are evidence of recruitment, that is increase in lung compliance based in the fall in the plateau pressures or for a given tidal volume. Then usually a response is noted during the first hour of the initial trunk, but sometimes it takes 12 to 18 hours are appropriate to ensure response, provide no life-threatening hypoxemia is present. In our institution, we saw the response from as early as 20 minutes to sometimes it took almost 4 to 6 hours. If it is a hemodynamic stably, we continued till we have waited for 6 to 8 hours for the proning. If the prone ventilation fails, or like no change in the patient gas exchange or lung mechanics or worsening of gas exchange or cardiovascular status, the patient should be returned to a supine position and alternate strategies of improving oxygen should be pursued, like ECMO. Then coming to the any complications, this is the core of the discussion is this potential source in the prone position. First, the patient must first examine first is our ability to bear the prone position. Like severe morbidity, the same contraindications will come here. The staff must ensure not to apply too much pressure, especially on the delicate part, face, small parts of the body such eyes, ear, nose, etc. Excess pressure may lead to damage of the body part. This pressure may not evenly apply to the hand, or also may obstruction of caused by arterial supply or venous drainage. It is not only per se the parts, but also arterial, venous, even the nerves. The dependent areas such as nose, forehead, breast, arms, chest, genitalia, and pelvis must be properly noted and addressed. This should be initially checked. Is there any breach of the skin or well documented? In case of any joint replacement, any negligence may lead to tissue injuries or dislocation. Direct pressure may lead to damage of the nerves. It could be taken care that nerves are applied with appropriate pressure only, like brachial plexus and this ocular damage might be results of two factors. The first one might be excess pressure on the eyes, while the second one being the poor perfusion. This may lead to severe damage and it should be well taken care of. Too much pressure can be transferred from the lower and abdominal limbs to the head, neck, chest, abdomen, and vessels. This may cause the corresponding areas to swell, thus producing obstruction to the airflow. Especially in the tracheostomized patients. Coming to the checklist, before initiating, we have to prone ventilation. We have to establish the enteral feeding, secure the lines, assemble personnel, perform safety pause, obtain pillows and position supplies, rule out contraindication, prepare the patient, place pillows, and the positioning of the limbs. Coming to the indication that according to same pro-saver trial with the refractory hypoxemia or the PF ratios less than 150 and with the respiratory failure, these are the indications for the use. Coming to the equipment, it is a team. A team consists of 4 to 6 members to reposition patient depending on the size of the patient, and 1 to 2 respiratory therapists who should look after the airway. The workers like airway manager and the monitoring. And for the first time, a doctor should be at the bedside is recommended. Regarding the pillows, 6 pillows, 1 flat sheet, face pillow, and the new ECG electrodes, which should be placed at the back of on the shoulders, and mepiplex to cut to the fit forehead and chin, and lateral loop and tapes for the eyes. These are the equipment needed. Precautions and the key points are the patient will be in the prone position 12 to 18 consecutive hours per day and is most beneficial when applied early within 36 hours after the intubation, which was discussed. During pronation therapy, patient is one-to-one nursing care must ensure all staff is informed of prone patient on the unit, that is on the floor, and a proning kit will be placed in the MIC supply room. Already discussed the contraindication where there is patient is whether it's an hemorrhagic shock or raised ICP or unstable spine, any uh, major trauma, fractures, and any bleeding. Pregnancy, the modified is a tracheal surgery or sternotomy recent. And when to, I mean, for discontinuation of therapy. So first one is the absence of response. Consistent PF ratios less than or deterioration compared to previous, that is 20%. And once a prone immediately of the prone therapy, if the deterioration occurs in 2 consecutive prone sessions. And other is the life-threatening deteriorations. Complication that may lead to immediate interruption of the prone therapy, that is oxygen saturation less than 85 or PaO 55 mg on ABG or requiring more than 5 minutes of the FiO2 1. And the unplanned extubation, any main stem bronchus intubation, I mean going the tube into the bronchial, any ET tube obstruction or substantial hemoptysis or cardiac arrest or heart rate less than 30 beats per minute, more than 1 minute, SBB less than 60 mm for 5 minutes. Regarding the actions, the first steps before pre-proning, then first we have to order or to place patient in prone position. Provider order is necessary due to the potential patient risk. Obtain baseline vital signs and hemodynamic measurements. These are need to evaluate or effect of the prone positioning. Perform and document physical assessment. Pay particular attention to the skin condition. Baseline skin assessment is necessary to assess for any changes associated with the prone positioning. Often any ordered baseline lab samples, baseline data are needed to evaluate the effect of the prone position like ABG. Provide sedation and analgesia with the neuromuscular blockade. Depending on the patient condition, paralysis may not be required. Aggressive control of pain and anxiety is essential for the position change to be effective and to prevent complication. And the one or two respiratory to secure the airway to prevent the dislodgement of endotracheal tube, and the respiratory will primarily respond for the ETT during the prone turn. Tube can come less secure due to increased oral and nasal drainage while prone. And the skin protection intervention, apply the Mepiplex to the forehead and chin, apply lacrylube or moisture drops to the eyes and tape eyelid shed, preferably with the kind removal tape. This Mepiplex protect the skin from the pressures and the shear injury. Patients which are high risk for the corneal injury, they lubricate or moisturize the base, and the minimal removal tape will potential eye damage. Secure the tubes, lines, drains, and note position of the tube for the references and documented. Where there is in the supine position where it is fixed, that should be checked after the prone also. If the patient doesn't have any orogastric, nasogastric, tube consider placing one prior to the proning. During proning procedure, disconnect and any capping of any non-vital tubes, lines, drains, and including arterial lines. Reconnect all the tubes, lines, drains after the completion of the term. This simplifies the proning process, decreases the potential that tube, lines, drains could be inadvertently dislodged. Then remove ECG leads and sticker from the front of the patient. These reduce anything that could create the pressure points. Keep saturation monitor on patient to assess oxygen saturation and heart rate during the procedure. Which are ECG are place patient back after proning. These are the pre-proning checklist we have to check. And coming to the proning, placing the pillow, first step, placing the pillows. With the patient in supine position, place 1 or 2 pillows across the upper chest. This will ensure the chest and shoulders are elevated off the bed. Chest elevation is critical to the airway, critical to airway maintenance. Place another pillow horizontally across the iliac crest and a third across the upper thighs. Place a thinner pillow over the shins. If the patient has a femoral line, position pillow around the device to ensure the femoral line is protected from the pressure. We can see in this picture that first pillow around the chest, second the iliac crest, and the smaller pillow is on the shins. Then positioning the limbs for turning. We turn the patient prone and supine with the face looking in the direction of the ventilator. Always the faces should be looking to the ventilator. And the arm should be positioned along the side of the body with the fingers pointed toward the toes. Keep the arms as close to the body as possible. Then feet. While patient is supine, cross feet at the ankles by placing the foot opposite to the ventilator should come on top. The next step is cover the patient with the lining. Place two lift sheet over the patient chest and the midsection. Cover the lifter and entire patient with the sheet. The sheet should cover from head to foot of the bed. The fold section of the sheet that is above the shoulder, so the patient head is not covered up. This is the picture we can see that with the patient is covered with the lining from head to toe and with the face opened up. Then coming to the sandwich technique, the sandwich patient between the sheet. Grab the both top and the bottom sheets together along the both sides of the patient. Tightly roll the sheets together like a tight jelly roll to sandwich patient firmly between the sheets. You can see in the picture that the down one and upper the linen sheets were rolled like jelly near to the patient. Then slide the patient away from ventilator. They slide the patient to the side of the bed away from the ventilator, which provides some slack for the ventilator tubing. Moving the patient away from the ventilator ensures sufficient bed surface for the pronation. Conduct first turn. The airway manager who is looking after the ET tube is responsible for determining when to turn. Prior to turning, review the expectation for when the to turn, like example say 1, 2, 3 or 1, 2, 3. Then review the plan for the turn as follows. First one, is there any other log roll using spinal precautions or hold tightly onto jelly roll at each side to secure patient. Turn patient to one side only. Following turn, airway manager to adjust ETT and tubing and preparation for the final turn. And complete the pronation. The airway manager is responsible for determining when to turn, and prior to the turning, review the expectation for this second turn. Airway and line placement takes priority and determines pronation speed. The pronation step possesses the greatest risk for the ETT, which is taken care by the respiratory therapist. And again, review the plan for the turn as follows. Slowly turn the patient through. Hold tightly on the jelly roll at each side to secure patient. Then airway manager to provide feedback and speed of turn according to the airway needs. And supporting the endotracheal tube and looking for the placement. And maintaining the neck alignment. In the picture, we can see that support of the head and neck and the arms around and ET tube placement. And this is a position of the legs, a small pillow at the shins, and the position of the legs should be hanged by placing a small pillow at the ankle. After then, again assessing the airway, following the proning, respiratory therapist to check the endotracheal tube at the distance from the teeth before proning, that is supine and after the proning. Any cufflink, pressure points around the tube and securement device, and check for any kinks in the tubing and the breath sound and ventilator parameters. And the document response to the turning, pressure relief strategies, and any assessment finding that are not within the defined limits. Document each deposition in the flow sheets and inspect skin carefully and provide padding to protect invasive devices. These are optimal prone placement which should be included. Secondarily, head repositioning, ongoing assessment and pressure relief of vascular devices and the tubes. Patient not lying on the tubes or devices. No electrodes on the chest that should be placed on the backside or shoulders. no EEG placement, and the eye moist and the lids closed all the times, which is padded. Pressure relief for knees. The node it's available. Donut shaped gel pads can be placed under each kneecap. Feet should be maintained at dorsiflexion at ankle at 90, no downward toe pointing. Dorsiflexion can be maintained by placing a gel roll or the under the lotion to raise the ankles of the bed. For the large-breasted woman, position breast laterally to reduce the pressure on the nipples or breast tissues, and the male genitalia should hang freely, or iliac rolls helps to raise the pelvis. Foley position between the patient legs. Shoulders should be relaxed and broad below chest. Avoid shrugging position as this can be lead to frozen shoulder or brachial plexus injury. Alternate arm position, dropping the arm below the bed surface and can help relax the shoulder. This can usually be done one arm at a time. Or a similar broad position, one arm above head and opposite arm outside can be tried. Protect against ulnar nerve injury with the nerve protectors or gel pad. Reposition frequently under the axilla or and be reverse tender bunk, slide head down. This should be able to slide hander and under patient's abdomen. That is, the abdomen should be free from pressure. This is a slide showing the pressure points from head to toe. Forehead, eyes, ear, chins, and anterior shoulder, which can look for the any nerve injuries. Then chest, breast, postal margins. We can see the place for the abdomen to hang freely, the genitalia, and the knees, the shins, and the toes. This is a picture taken for the awake proning for summarizing the 5 steps. First, prepare. You have to explain the procedure to the patient, and we have to obtain the consent. And we actually, with the help of the patient, or by educating the patient, or with the help of 2 or 3 persons, we ask the patient to turn slowly. Second is the position. First, take the bed flat. Ask the patient to turn themselves on the tummy to provide assistance. First pillow slowly under the chest or under the abdomen, and second pillow rolled over a small one on the forehead, leaving a gap to communicate the face mask. And the oxygen supply and interface according to the HFNC or NIV. That mask should not be being pushed against the patient face. It should be taken care of. Then this optimizing the position based on the patient comfort and the abdomen distress. Will take the position either some angle or up or down. This is the first for the first time. The second from second position onward, the patient is well educated and he can do by himself. And the final, the monitoring based on initially they may drop in the saturation. It should be before only increase the oxygen supply and wait for proning. This concludes this class, and over to the moderator.
Thank you, Dr. Venkanna. Thank you for that detailed presentation regarding proning and what we need to do. So right now, I think after you heard the presentation, few important points that you need to think or keep understand. One is proning is especially important for us because of the present pandemic going on and for increasing indications in our ICU and in other setups. And once we know importance is once a patient is prone, most of the time in an ICU patient is under relaxation, muscle relaxation and sedation. So it becomes an extra responsibility on our side to be extremely careful regarding his positioning. We make sure that first, as the first rule of medicine, do no harm. So first make sure that there is no harm to the patient. Only then can we really give him real help from this positioning. So I think there are a few questions coming in. Everybody's encouraged to ask any questions to us. We'll be happy to answer them. And if anything, after that, after a few questions, we can just come to a quick short session on MCQs so that we can just review what you have read so that we understand them and see how we can apply them in our daily life. Yeah. So the first question I can see is from, one second, from Mr. Arnav. Is any benefit from left or right lateral position if patient has and distension? Okay, so I'm understanding, is there any benefit from positioning the patient in left or right lateral or left lateral position if there is abdominal distension or post surgery? So, Mr. Venkanna, can you
Yes,
help
sir.
out?
Yes, sir. There is obviously we saw in the patient is completely can't prone the position. We maintain with the lateral position that too, and minimum session like few hours for right lateral and the left lateral. The sides were maintaining, but we observed that whenever there is diseased lung which is there, it should be the downwards. Down to the bed. The normal chest, normal which is less involved lung should be the upwards.
Yeah. So what we would say is what we have seen generally in, especially now in the COVID pandemic. Sometimes we are unable to place the patient in a complete prone position, and sometimes we have been forced to place, as said, in the left or the right lateral positioning. And there too, we have seen few improvements, especially sometimes in cases like when we have done with ECMO patients, where we are really worried about the lines and especially the big ECMO cannulas. So we have seen that lateral position itself has helped. I'm not sure of any study which has been particularly made with regard to this, because usually post-op patients, real abdominal distension, it is a complicated area, and most of the times along with ARDS, if it's a really post-op, post-surgical patient, tend to have much more pressing issues. So it is sometimes difficult, but yes, any barring even lateral positioning to an extent has shown good improvement in oxygenation. Yes, the second question I can see is what about the patient with tracheostomy?
Yes, sir. We have done the patient on tracheostomy also. That a bit careful is that we have taken the we should we should be careful about the tracheostomy tube. There should be gap between the adequate at least 3 to 4 centimeters from the trachea to the chin. And second is a dislodgement of the trachea is you should take care for that one.
Yes. So with tracheostomy, what we have our experience here, what is in it can be, it is done, it can be done pretty easily. Yes, we need to be extremely careful because the neck area is a little short. We need to maintain adequate distance between the chin and the upper chest. Around, we usually target around 3 to 4 finger breadths, or around 3 to 4 centimeters as told. And what we do at our is, because tracheostomy are really worried about positioning, dislodgement, sometimes we take a stitch around the for the tracheostomy so that it's fixed better, and we keep a close monitoring to it. And more importantly, we need a good catheter mount and extension so that we are able to deliver those breaths better. Yeah. Any other questions? You can keep coming up with questions. We'll be here. We are here. Until then, I'll just share my screen for the next questions. So, Dr. Venkanna, I'll be stopping your screen share and I'll be sharing.
Okay, sir.
Yeah, so I hope you can see this. Hello? Yeah. Sorry, I think I lost my chat bot. 1 second. Yeah. I think there are a few more questions. We'll just maybe we'll just do the MCQs and we'll come back to those questions. I hope that's fine. Yeah. So first, yes. So as we part of these questions, we'll just have a review of them. Everybody is encouraged to participate in these questions. Please try to answer them in the chat discussion. We will come back to those questions as we need to complete this part of the discussion. Okay. So the questions. See, the questions are, they just read the question carefully before answering. These questions are based purely on today's topic, and sometimes more than one answer may be correct in them unless we have specified. Okay. So the first question, indication of for proning are all except. So first option ARDS, second patient on for the hemorrhoidectomy, third COVID pneumonia, and fourth a posterior fossa surgery. Okay, I see a lot of D's, some A's. So the question is very straight. Indication for all except. There's sort of D's, sort of B and D's. Okay. So the answer for this question is, see, indication, if you look at the question now, how do you answer? What are the indications of proning? We do it primarily for somebody who's in ARDS. So ARDS is obvious answer. Second, in COVID pneumonia, it has become mainstream. It is the procedure to be done. It has shown improvement along with steroids, so that becomes an answer again. D, posterior fossa surgery. There is the positioning where you need the patient in the prone position because you need the access of the posterior fossa of the brain through that. So that is another indication of proning. This primarily happens in the OR, so not so commonly in the ICU, but that is definitely indication. If it's a patient goes for hemorrhoidectomy, the position is not prone, but in more of a lithotomy position where you have seen the tube. So the answer will be B. Next question, ischemic optic neuropathy, a known complication in prone position, is caused by injury to what? So the options are A, cornea, B, vitreous, C, retina, or D, optic nerve. So this is for question number 2. Any responses? Yes, so I see a lot of D's, some C's. Any other possibilities? So yes, since I'll go with the majority, the answer is D, which is the injury to the optic nerve. This is in the name itself, as you can see, ischemic optic neuropathy. So there is ischemia where there is decreased blood supply to the optic neuropathy. So any neuro or the nerve, that is what it means. So that is a known and a very dreaded complication that we have due to prone positioning, and we need to be extra careful regarding this. And that is where the focus on regarding pressure points, regular monitoring, change of positions are important. Now coming to question number 3, true or false regarding proning. This is all questions. So first question, there is improved ventilation, distribution, increased FRC, and decreased shunt. Is that true or false? So this is a 4-part question, so we'll go one by one. So first, option A, is it true or false? Yes, it is true. You can see that is the reason that we do proning. It helps improve ventilation, distribution, FRC, decrease shunting. Second, feeding should be stopped during proning sessions. I think I've already seen a completion of the answer. Very good. Any more responses? So what we do is B, feeding should be stopped during proning is false. Feeding can be done. Yes, we need to keep a close monitoring, but nutrition and other targets should be continued because in proning sessions, most of the time the patient is prone for a much longer time than when he is supine. So we need to maintain the nutrition targets also. Option number C, proning is absolutely contraindicated in pregnancy, ECMO, and post-abdominal surgery. The answer here, yes, I think there's somebody has raised a hand. The answer is proning is absolutely contraindicated. Pregnancy, yes, to an extent, a lot of people are very cagey regarding proning in pregnancy. It has its risk, increased monitoring. But in ECMO and post-abdominal surgery, when the abdomen is closed, it can be indicated, can be gone ahead. And option D, defibrillation can be done in prone position. Yes, that is also true. It can be done because defibrillation is something where we not delay it and we need to do it as soon as possible. So defibrillation can be done in prone position with patch, and then we can turn over for immediate back to supine for CPR or any others. So the correct answer for this would be T, true, false, false, and true. I think one of you got it. Congratulations. So next, the question, which trial showed a mortality benefit with proning? So the options are ARDS net, DEXA ARDS, ProSeva, and Caesar. So the question is, which trial showed a mortality benefit? So we see a lot of C's, so it's good. So I guess we go with the option. So C, yes, C is the answer. C is ProSeva. Even if, let's say, sometime we don't remember C, what to do it? Proning. It's called Pro. So it is about proning, Seva. You kind of save the patient with this. So that it does show a mortality benefit. So it helps you save ProSeva. So why proning? You have kind of saved the patient. And that's what it has helped. All other trials also have shown benefits. ARDS net was the first one which showed the lower tidal volume, high PEEP support. DEXA ARDS, which was done recently for the COVID, which showed the help of steroid in COVID pneumonia. Caesar trial was done primarily for the ECMO patients, and this will show that ECMO can, to an extent, help in improving mortality. Fifth one, how to improve proning practices in the ICU. Option 1, regular training and simulation. B, good role allocation. C, appropriate documentation. And D, all of the above. So the answer, I think everybody's got it. Its answer is D. So we need good training and help of simulation to help the team understand the dynamics which happen with regard to proning. And simulation is a very good way to understand what problems we might face, what logistical issues we might face, such as switchboards, bed positioning, hand modular positioning, everything makes a difference. Role allocation, extremely important. Everybody needs to clearly define their role and identify, as we said, as Dr. Venkanna had clearly mentioned, we need to have an airway guy, we need to have a monitoring person. Everybody is to have it clear about what they need to do. And then appropriate documentation. That is very important to know whether the proning was successful, when was it started, when are we planning to change the position, and any other complications associated. So next question, this is a little tricky, more clinical. This is something which you may or may not have faced, but I'm sure in our team quite a few people have seen this. So sixth question, 5 minutes after proning of a severe ARDS patient, we have seen that there is a fall in the saturation, fall in the blood pressure, and the alarm is giving you a high peak pressure alarm. On the ventilator, it's blaring high peak pressures, high peak pressures. So what could be the reason? Okay, so 1A, ET endotracheal tube compression, B, abdominal compression, C, a defective monitor, or D, pneumothorax. Now remember, there are, as we said, unless specified, there might be more than one answer. Okay, we see a lot of A's, we see a lot of A and D's. Nobody likes B. What about C? So let us approach each option as it goes. Yes, endotracheal tube compression. Yes, if the tidal volumes don't get delivered properly, the peak pressures, resistance goes up. The manipulator will talk about high peak pressure alarm. This usually gets picked up early because if you have seen it, and but if there is a delay or there is everybody is held up in some other problem, then that eventually can lead to hypoxia, that is the fall in the SpO2 and later on to fall in the blood pressures. But that is much ahead. So, but ET compression, yes, it can cause, but it is a very late complication to have all three together. Secondly, immediately 5 minutes abdominal compression, that can cause a problem because immediately once we prone the patient, we need to show that the abdomen is free. Why is that important? Because any abdominal compression immediately can cause two things. One is increase your airway pressures, or decrease your compliance because they increase more pressure because the abdomen is pushing there above the chest, so you need more pressure to open the lungs. That causes a fall in SpO2. High abdominal pressure or increased pressure in the abdomen causes a decrease in the venous return of the blood to the heart. That can make the fall in the blood pressures, and all this can show up. So that could be, and we have seen a lot of times this tends to happen because, especially in obese patient, very FT patient, or sometimes in a hurry when we prone the patients, these changes can happen. So immediately once they relieve the pressure and everything settles down. C, defective monitor, unlikely that only all the monitors go defective. And D, pneumothorax. Yes, that is also a dreaded complication that can occur. We have seen this happen, especially more during the COVID times, where a sudden change in the peak pressures cause for a pneumothorax going, especially something with a pneumothorax with high pressures and a fall in saturation pressures. It will cause primarily what we call as tension pneumothorax. Next, what is recommended time in prone positioning? Question 7, 24 hours, 18 hours, 16 hours, 8 hours. Question is there a right answer? Is there a right time? 1 second. Dr. Keshav, can you take this question, please?
What is the recommended time in prone position? According to ProSeva trial, the best is the 16 to 18 hours.
So yes, as Dr. Venkanna has said, yes, it can range as per the ProSeva trial. It was usually targeted for 16 hours, but it can be extended. Sometimes can be shorter depending on the responses, how the patient responds, whether in a positive way or a negative way. Sometimes we have extended even up to 20 hours initially in COVID at times where we have seen improvements. Next question, complications associated with proning include A, pharyngeal edema, B, pressure sore, C, nerve entrapment, or D, venous air embolism. Again, the answer can be more than one. That's the clue for you. We see a lot of B's. There's an A, B, C. Very good. Any more responses? So we see a lot of ABCs, AB, ABDs. Dr. Venkanna, can you help us out?
So, complications associated with proning include based on pressure source, nerve entrapment, and the dependent like pharyngeal edema also.
So as you can see, the options, actually all of them can happen in various frequencies. But usually what we are more worried about in proning are the edema, the pressure source, the entrapment, the pharyngeal edema based on the positioning and how we locate around the neck position. But yes, sometimes in OTs, and we have seen sometimes in our ICUs also, because of the poor access, or sometimes in posterior fossa surgeries, embolisms can occur. So we need to be careful regarding that too. They too can happen, although rarely, but yes. So all are a possibility, all are possible complications. Yes, so how venous air embolism? See, sometimes there are indications. See, most of the time you are proning, there is a central line. There are, in an ICU setup, let me talk about. Major where you have seen is this tends to happen when the patient has a dialysis catheter. Sometimes the dialysis catheter can get disconnected, or and it gets opened up into the air. But times when you're busy, it might happen. Sometimes during disconnection from the dialysis technician, it might happen when they're just in a hurry, they might not close it properly. And sometimes if there's a dynas connection with the air, it can suck in, and or sometimes the patient during this time, patient becomes awake and he has a large negative pressures build up. He can just suck in a lot of air, and immediately you have seen that patients have dropped in. Can happen, not a very common complication, but it can happen. It does happen more in the operation theaters, especially in the spine and in the posterior fossa surgeries, where the all the vessels are exposed to the atmosphere, and at that time any fall in pressures and all can cause a negative gradient, and this can happen. Question 9, discontinuation of proning is indicated in all except 1, improvement of oxygenation, B, cardiac arrest, C, displacement of endotracheal tube, and D, a high Riles tube aspirate. So this is the last question. Discontinuation of proning is indicated in all except. So here it's a single answer. That's the clue for you. So see, now I see a lot of B's, lot of D's. So if you look at the question in its parts, so when do you discontinue proning? 1, if there is improvement on oxygenation, where the patient, once we do the proning primarily so that because his oxygenation is going bad, we want it to improve. So if there is an improvement, slowly we can discontinue it because we know it's further is not required, and maybe we can come down on supports on supine. Second, cardiac arrest. If a patient has a cardiac on proning, it is extremely difficult to provide any kind of supports, especially chest compressions, and ideal would be to supine, make him supine, and go the best possible way to revive. Third, any displacement of the endotracheal tube, that too warrants a change in the positioning, especially disconnections, or it is complete. If it gets, there is an accidental extubation of the patient in that position, then again your access is blocked, and you need to ensure that first the airway is secured, and you need to again supine the patient, secure the airway, and then go back to the patient. Option D, high Riles tube aspirate. This can be a problem because you are in an odd position. There can be some amount of abdominal compression. There is, because of the so many medications, the stress in the body, there is a possibility of ileus happening, and you might see that in spite of reasonable good RT feeds, there is a large aspirate coming in. So that does not immediately warrant a discontinuation. We can continue the proning, and then afterwards, once we are back to a better position, have a better look at why this happened. So that concludes the questions. I'll just go back to the previous questions which were posted. I would request if somebody, the previous questions which we had unanswered, they can just post them again. That can help us out. I'm just stopping my screen share. Yeah. You just see. Any other questions? Any other comments are welcome. How long time to prone patient? How much time to prone a patient on proning? I think that we have answered that to the questions. Prone position and APRB without sedation. Your experience. Any experience, Dr. Venkanna, on APRB with proning without sedation?
We have that APRV ventilation 2 or 3 patients are in third wave, I guess. But the patient having high support, inotrope support, sir. We could, I mean, whenever he's awake, there's a lot of secretions and couldn't maintain. So we try to sedate it with infusions only, but we couldn't make that one. But at that time, we have changed the mode APRV and went to other mode.
Yeah, so our experience, if you asked us in APRV with prone position, it's not very big. See, any positioning in prone, unless it is awake, or maybe sometimes with NIV or HFNC, we have seen that we are able to get away with prone positioning. But intubated patient without sedation, extremely difficult because the tube will irritate him. There are other concerns. So our experience is very poor. I personally would not recommend that. Maybe with there should be some sedation. Without relaxation, yes, I would say that is the advantage an APRV can give you. So without a muscle relaxation to help you tide over, that can be done, but there is definitely we need some form of sedation there. How can we feed the patient if the patient is on Riles tube? That's the question. Mr. Venkanna. So I understand the question is basically the patient has a Riles tube. How do we give it in a prone position? I think that's what was trying to be told. I think that's the question.
Yeah, actually, it is done in the for few patients, 24 hours proning, awake proning. We used to feed them with the sippers. I mean, liquid food, sir, with the sipper. The patient used to the same prone position for almost 20 to 24 hours. So we used to give the tumbler with the sipper. They should take that one, but they are the HFNC only.
Yeah. So yes, the last question now, because I think we are falling short of time. So we'll just finish up the last question. Any further questions or discussions or comments, you can contact us directly, or you can get our IDs from the ICCR. We'd be happy to help you out. So last question here: best sedation protocol or drug for such prolonged cases?
Okay, best sedation protocol. I mean, protocol we don't have, sir. I mean, we first intermittent boluses of opioids only. Then the patient is comfortable. We switch to the dexmedetomidine. Like there is no peak pressures or high peak pressures or can tolerate. We went with the dexmed sedation only.
Yeah, so best sedation protocol depends on the presentation, but usually what we see is when the patient is in severe ARDS and all conditions, it is very difficult to just get away sedation. We usually add a muscle relaxant, especially atracurium or cisatracurium, what is available, and we need to continue that. And then later on, once we come down with sedation, our practice here, we start with fentanyl and opioid and with atracurium. Dexmed, we do add it later in the second day once we see that the hemodynamic stability and we feel that there is a better control on the patient, and we do continue with the fentanyl along the way. So that's it. Any further questions, you can just contact us directly, or you can get our mail. We'll be glad to help you out. Thank you so much, Dr. Venkanna, for taking out your time for presenting. Thank you, ICCM, for giving us this opportunity. And again, thank you so much, and a very good afternoon from Kim Hospitals. Thank you so much.
Thank you, sir.